Good afternoon, everybody. Welcome to our Lunch and Learn entitled The Role of Language in Pregnancy Outcomes in Quebec. I'm Lorraine O'Donnell, Senior Research Associate and Advisor, Quebec English-Speaking Communities Research Network, known as QuestGrant, and Affiliate Professor at Concordia University. I will be moderating this Lunch and Learn. Before continuing, I would like to acknowledge that while we meet today on a virtual platform, Concordia University is located on unceded Indigenous lands. The Ghanaian-Gahaga Nation is recognized as the custodians of these lands and waters. Chojoke, or Montreal, is historically known as a gathering place for many First Nations, and today it's home to a diverse population of Indigenous and other peoples. We continue at QuestGrant to reflect on ways in which we can work in collaboration with Indigenous communities to form mutual and ongoing relationships. This event was made possible through the financial support of the Secrétariat aux relations avec les Québécois d'expression anglaise. QuestGrant also receives funding from Canadian Heritage, the Canadian Institute for Research on Linguistic Minorities, and Concordia University. Please note that this is a space for intellectual exchange. Any views or opinions expressed in this talk do not necessarily represent those of QuestGrant or its funders. It's now my great pleasure to introduce our speaker today. Dr. Nathalie Auger is an associate clinical professor in the School of Public Health at the Université de Montréal and a physician in the Department of Preventive and Public Health Medicine of the Centre Hospitalier de l'Université de Montréal, or CHUM. Her research specialty covering various aspects of maternal and child health. Nathalie's two recent publications address causes of ethnocultural inequality in pregnancy outcomes, as well as the impact of hospital choice on birth outcomes for English speakers in Quebec. So I'll now turn the floor over to Nathalie. Nathalie, we're a couple of minutes early, so I will now leave the mic to you.
Thank you. That was a lovely introduction. Thank you for that. So it's a real pleasure to join everyone today. I'm going to give you an overview of our latest research on pregnancy outcomes in Anglophones of Quebec. Okay. I'll start out with some context very briefly, and then present two studies. The first one will be rather quickly. We'll pass through it, spend a bit more time on the second one, and then if there's time, look at a bit of the future research that we'll be doing, and then answer questions after that. First, just some acknowledgements. I really want to thank Dialogue McGill for funding our research all these years. It's been a very long time now that they've been funding our work, and we are very appreciative of that. Also, the Fonds de Recherche du Québec, and two people, Marianne Bilodeau-Bertrand and Tara Lafleur, that I'm grateful to, who have produced the statistics, we've worked together, going back and forth, trying to better understand the health status of our population, and this work wouldn't have been possible without them. So we are in a population health surveillance team at INSPQ that has a double mandate. The first mandate is maternal infant health surveillance. So we monitor the health of pregnant populations, try to understand their health needs, try to identify emerging inequalities, and we do this using administrative health data. Our other mandate is research on maternal and infant health, which I carry out at the CHUM. So some background context. Our previous research related to linguistic communities suggests that there may be some emerging pregnancy disparities among Quebec's Anglophones. Amongst those pregnancy outcomes. I'll speak about two in particular, stillbirth and preterm birth. So a stillbirth is the death of a fetus while it's still in the uterus. And a preterm birth is the birth of an infant before 37 weeks of gestation. Both are unwanted. But in particular, stillbirth is not something that any pregnant person wants. They're both indicators of perinatal health. They're used worldwide as indicators of perinatal health. So I'll just show you some background statistics on what I mean by emerging inequalities amongst the Anglophones. So on the left here, we've got the preterm birth rate, and on the right, the stillbirth rate, in different time periods, different decades. This is the Anglophones on the left, Francophones on the right. So we see here that this is essentially the percentage of births that are preterm. In the 80s, it was 6%, and by year 2000, we're looking at around 7 or 8%. So there's a slightly increasing trend, and that increasing trend is also occurring among Francophones, but more so among Anglophones. It's occurring more quickly and going to a little higher rate than the Francophones. In terms of the stillbirth rate, I'll just ask you to look side by side. So currently, right now, there are more stillbirths among Anglophones than Francophones in terms of 4 per thousand, 4.4 per thousand among Anglophones, as opposed to 3.3 among Francophones. That was inverted earlier on, before in around 1992, 1989. So these are some emerging inequalities that we're going to be interested in and try to study. So we don't know why those inequalities are there, and I can't explain why, but our rationale in the present two studies was try to understand whether some access-related issues could be related to that. So the question specifically is, could access-related issues explain some of the perinatal health inequality in Quebec's Anglophones? So just so everyone understand how healthcare is provided in Quebec, almost all deliveries occur in hospital, and we were wondering whether care-related barriers related to language could be driving some of the inequality. We're using an epidemiological approach. Our team does not specialize in the delivery of an organization of a healthcare system that cannot answer those kinds of questions. We're looking at statistics of the health of the population in the following slides. So I'll begin with the first study. Just a reminder, this will be a bit of a fast, not going to show too much information about this study. The hypothesis of this study was that longer travel times to reach the place of birth or the hospital could potentially affect the timing of birth. Anglophones may choose to travel to a farther hospital, specifically to select an English-speaking hospital, as there are fewer in Quebec, but there are available English hospitals. So some Anglophones might choose to go to a farther hospital. And the hypothesis is that this could delay delivery and potentially lead to a stillbirth. Now, preventing stillbirth means not letting the birth go a bit too long before the kind of death of the fetus occurs, because the risk of stillbirth increases when it takes longer to get to a hospital. The objective of the particular study was to evaluate whether distant travel to reach the place of birth or the hospital of birth contributes to the risk of preterm birth and stillbirth in Anglophones compared with Francophones. So in this study, in terms of the methods, we are using vital statistics data. That's live birth and stillbirth registration certificates. When your child is born, you fill out a form and you register the birth. That's what we're using, the data on those forms. It is a retrospective cohort study. Sorry for these words, they're not important. And basically, we're using all the births in Quebec. It's 1.2 million births among urban Quebec that we're analyzing. So specifically urban areas. We're not analyzing rural areas here. And in this particular study, we only included Anglophones and Francophones. So in any epidemiologic analysis, we have an exposure and we have an outcome. Here, the exposure is the maternal mother tongue. So the language that the mother reported, she used as her mother tongue on the birth certificate. It could be either French or English. The other exposure we're interested in is how long, the distance between where she lived, her postal code of residence and the postal code of the hospital. So that could be either less than 10 kilometers, 10 to 30 kilometers, or 30 kilometers or more. There were two outcomes, again, preterm birth and stillbirth. Okay, so every epidemiological study has a statistical analysis. Basically, we use regression models to obtain a kind of measure of association. In this case, it's a risk ratio. So this is a number that consists of the risk in two groups. One, in this particular case, so the example is for stillbirth. So the risk is essentially the proportion or the percentage of stillbirth amongst all the births. So this is essentially the percentage of stillbirth among Anglophones divided by the percentage of stillbirths among Francophones. If the risk in Anglophones is 5%, for example, and the risk of stillbirth in Francophones is 4%, or say the numerator, the number on top, is larger than the number on the bottom, making it be that the risk ratio is going to be above 1. So if we see a number that's above 1, that's what you want to click in your head. That is the number that's a little bit more concerning for the person the group that we're investigating. If the risk ratio is 1, it means there's no difference between both groups. If the risk ratio is below 1, it means the risk for the Anglophones is lower than the Francophones, so the Anglophones are better off. All these things are adjusted for what we call confounders or other factors that might be contributing to the association. These other things are accounted for in the risk ratio. So the thing to take away from this slide is we're going to be looking at risk ratios. Above 1 is what you are going to focus on. Okay, before we get to the risk ratios, first we're just going to look at some percentages, some frequencies of preterm birth and stillbirth, according to how far the hospital is from your home. So again, on the left is preterm birth, on the right is stillbirth, and I'll ask you to look only at what's in the percentages. Those numbers is just the number of births. You can ignore them for now. So in terms of the preterm births here, we've got Anglophone on the left, Francophone on the right. Within 10 kilometers from home, 3.8% of births among Anglophones are preterm. Amongst the Francophones, that is 3.3%. Slightly higher for the Anglophones. If we look at the stillbirths, similar kind of thing. 0.3% among Anglophones are stillbirths. 0.2% among the Francophones are stillbirths. So again, a little bit higher for the Anglophones. Amongst those Anglophones that go much further, who are able to do so, travel to, take their car or so on, all of them have a much lower rate of all these things. These are more advantaged people. But the Anglophones that do this have a very low rate of preterm birth, and also compared with the Francophones. Everyone has a low rate, but Anglophones have a low rate compared with the Francophones, 0.6% versus 1%. And same thing for the stillbirths, 0.04% versus 0.1%. So now we're going to just transform this into risk ratios on the next slide. Anglophone versus Francophone. Again, so Anglophones on the numerator, Francophones on the denominator. Here is the risk ratio for preterm birth and the risk ratio for stillbirth, adjusted for all those other little confounders. So within 10 kilometers from home, if you're Anglophone, you have 1.07 times the risk of preterm birth. These are not huge numbers, but they're slight differences between the Anglophones and Francophones. Anglophones are more likely to have a preterm birth and a stillbirth if they're having their birth at a closer to hospital. They can't displace themselves to use that more further hospital. Now, these Anglophones, you see, they have a much lower risk of both preterm birth and stillbirth. Usually, these are more educated Anglophones who are able to do so. Okay, so that's the. I mean, you could keep this in mind. So the people of concern are these ones here that are delivering closer to home. What do we conclude from these slides? Anglophones who deliver close to home have a greater risk of stillbirth and preterm birth compared with Francophones. Those who travel farther have lower risks. And what it tells us is that that hypothesis on the first slide is not correct. Longer travel times does not explain why Anglophones have more stillbirths. It does not explain why there is this emerging inequality between Francophones and Anglophones. It has nothing to do with how far you have to travel. So based on the results of this study, we kind of switched our angle to wonder, could there be some other factor related to possibly the language of the hospital? Okay, before we get that there, I'll just point out that every epidemiologic analysis has certain limitations. We usually show a slide like this, or you can ignore it. But anyway, I always feel obligated to show these things, like there can be coding errors, the usual kind of errors in a statistical analysis that can be present. All right, so moving on to the second study, which I think is the more important study. I'll spend more time here. Now, here the purpose was to look at the hospital characteristics and the risk of stillbirth and preterm birth only among Anglophones and only in Montreal. So you have to kind of reorient your mind now. We are not including Francophones in this study, only going to talk about Anglophones only. The hypothesis here is that amongst Anglophones, there could be potential language barriers that are related to adverse birth outcomes. We hypothesize that delivery delays could be more likely among Anglophones who use French hospitals as opposed to English hospitals. One thing I'd like to point out before we move on is that there is a fine balance between preterm birth and stillbirth. Those two are very related. Nobody wants a preterm birth, as I mentioned, but a preterm birth is what happens when you want to often prevent a stillbirth. So in some situations, a preterm birth is good. There are many causes of preterm birth. Preterm birth occurs for many reasons. One of those particular reasons is that we want to avoid a problem in the fetus, which is normally death or some other kind of unwanted outcome in the fetus, or we want to protect the health of the mother. So please keep that in mind, that preterm birth is not always a bad thing. The objective of this particular study was to determine the relationship between the language of the hospital, so no longer the language of the person, of the pregnant person, it's the language of the hospital, and the risk of preterm birth and stillbirth among Anglophones in Montreal. We're using the same data, vital statistics, which is the live birth and stillbirth registration certificates. Same kind of study design. This time the population is smaller because we are only including Anglophone people in metropolitan Montreal. So that's about 125,000 pregnancies. since 1989. Again, there's always an exposure and an outcome in an epidemiologic analysis. And in this particular case, the exposure is the language of the hospital. It is not the language of the mother. So there are actually three kinds of exposures that we're looking at. There's the local hospital, no matter the language. Those kinds of hospitals are attended by women that have normally very healthy pregnancies, usually no problems, expected to have a healthy delivery, versus two other kinds of hospitals, an English hospital that's a bit further from home, a little bit further, and a French hospital that could also be a little bit further. Those two kinds of hospitals are used by pregnant women that might have a bit more complicated pregnancies. Either they have a gestational diabetes or they have hypertension, something like this, or some other issue that's causing them to go a little bit further from their home to use either an English or a French hospital. Same outcomes, preterm birth and stillbirth. So we will be comparing those two kinds of hospitals, French and English, with the local hospital. In terms of the analysis, the risk rate is the same thing. Our regression models, we're obtaining risk ratios. I really apologize for this. I understand that it's hard to switch. I also want everyone to know that this project was very complicated for us to figure out how we would measure the exposure, how we would measure the outcome. It was not a simple thing. It took a lot of time and thinking. So you do have to be listening and paying attention, particularly here. So the risk ratio, again, has nothing to do with the language of the mother. In this particular case, it is the hospital type. So either we are comparing the percentage of stillbirths in a French hospital that's a little bit further from home, divided by the percentage of stillbirths in a local hospital. So the risk ratio, if the risk of stillbirth in the French hospital is a bit greater, so if it's like 5%, we'll have a 5 here, and if it's 4% in the local hospital, those are not realistic percentages. I'm just making them up. So again, the risk ratio will be greater than 1. We're looking for that. If the risk ratio is 1, it means the risk in both, there's no difference between that French hospital and the local hospital. Again, the risk ratios are all adjusted for confounders, other possible explanatory factors like maternal age, how many previous parity is the number of previous pregnancies you've had already, your country, the maternal country of origin where the mother was born, her level of education, her deprivation status. Material deprivation is an indicator of the wealth of the neighborhood where she lives, and the time period. Now, first, I'll show you 3 sets of tables. The first set of table is only the percentage of births that are either preterm and stillborn. So again, this is only Anglophones. I'll ask you to look at what's in the percentages only. You can ignore the numbers of births themselves. 7.7% versus 8.4% when we're looking at the percentage of preterm births in a farther French hospital versus farther English hospital. So an Anglophone woman who uses a farther French hospital has a slightly lower chance of having a preterm birth than an Anglophone woman who's using a farther English hospital. She's more likely to have a preterm birth. In the hospital closest to home, I mentioned that usually those are uncomplicated pregnancies. The preterm birth rate is lower than anybody here. Okay, so this is expected, and the higher numbers here are also expected because those pregnancies are a little bit less healthy. in terms of stillbirth, we see a reverse pattern. So if the pregnant Anglophone delivers at a farther French hospital, 0.6% will be stillborn. If it's a farther English hospital, 0.4%. So slightly higher in the French hospital than in the English hospital. 0.3% in the hospital closest to home. Okay, let's move to the risk ratios. The chance of having a preterm birth in an English hospital is equal to the chance of having a stillbirth in an English hospital that's further away from your house compared with a local hospital. When we go to the French hospital, that balance shifts. You're now less likely to have a preterm birth compared with a stillbirth. You're more likely to have a stillbirth when you go to a farther French hospital compared with the local hospital. So I don't know if I succeeded in illustrating the inequality here. The problem is that we want something like this. We want similar, this is a better situation. It suggests that the woman who's going to that farther English hospital is getting that preterm birth. She wants it. She needs that preterm birth to prevent the stillbirth. All these women, because they're having a little bit less healthy pregnancies, are going to have more preterm births than stillbirths. You cannot help that. But ideally, we want to minimize, lower this number and increase this number. So that is a bit more balanced in English hospitals than in the French hospitals, where there appears to be more stillbirths relative to the preterm births. So what we've done here is divide up the Anglophones into different kinds. So a more advantaged or more educated versus less socioeconomically advantaged, according to their education level. So this is the same table as the previous table, but split up. We split up these people, the Anglophones, into their level of education. Okay, so I'll ask you to just look at the last row here. This is really very interesting and the perfect scenario. This is what we want to happen and to see, which is that essentially if an Anglophone woman goes to an English hospital, she has a very high rate of preterm birth and almost very low rate of stillbirth. She's much more likely to get that preterm birth if she's university educated and goes to an English hospital that's like farther from her home. That same woman who does not have a high school diploma, well, it's not as optimal for her. The risk is the same. So you're just as likely to have a preterm birth as a stillbirth. What I'm showing here is just like the balance is shifting. This university educated Anglophone who goes to an English hospital gets what she needs, which is a preterm birth, as opposed to a stillbirth. The one that has no high school, it's not as ideal, but it's still a little bit relatively balanced. Now, here is the problem when this high school person who does not have high school goes to the farther French hospital, where unfortunately that balance shifts completely, where the risk of stillbirth now triples, and she's not very likely to have a preterm birth. Now, if you want to look at her chance of having a preterm birth is like completely flipped. So if we looked at the university educated woman who is at an English hospital, her chance of having a stillbirth is 1.1, and that's exactly the chance of having a preterm birth for that person with no high school diploma. So just in your mind, we want the preterm birth. Okay, this is a good thing to have. When we're comparing this row with this column against the stillbirth column, we want a preterm birth, and we want the number here to be higher than 1. The higher, the better. And we want this risk ratio to be as small as possible, to be as close to 1 as possible. The problem is this group here, oops, I'm sorry about that, where those less educated Anglophones that are using a French hospital are not getting the preterm birth. They're instead having the stillbirth. I'll come back to the slide at the end. Okay, so that's the main finding of the study. I'll just highlight the limitations as essentially similar to coding issues that we discussed in the other study. We didn't know the level of care of the hospital here. We just grouped all the English hospitals, grouped all the French hospitals, and did not distinguish hospitals at all. The other thing I want to point out is that I mentioned that preterm birth is something that sometimes we want. I don't want to suggest that a preterm birth is good in any way. All it does is prevent a stillbirth. There's no guarantee that a preterm infant who's born alive will survive or be healthy. Ideally, we want a healthy pregnancy with neither of those outcomes. Okay, so what we conclude here is that Anglophones who use French hospitals have a greater risk of stillbirth than preterm birth, less healthy Anglophones. In contrast, Anglophones who use English hospitals have a more balanced risk of both these things, and this disparity is greater if you are socioeconomically disadvantaged. We can debate on what's leading or causing this. Some of the things that come to mind could be language barriers in the hospital or other factors that are causing the patient not to go to the hospital fast enough. There are numerous possible explanations that we can't answer in our data because we don't have the information. Okay, I'll just very quickly highlight some of the future research that we're trying to do that is just got funded by Dialogue McGill. We're trying to understand why we're seeing the trends we're seeing. And right now what we're looking at is maybe some of the morbidities in the women that could be accounting for the inequality between Anglophones and Francophones, gestational diabetes, which is diabetes that are high blood glucose, that blood sugar that manifests first time in pregnancy. That's not a good thing in a pregnancy. You don't want to have high sugars. Preeclampsia is what that is a high blood pressure. That's another thing that's can be quite dangerous in pregnant women. So we're looking at both these things, and we're doing it by using vital statistics data and also some hospital data. These are some preliminary statistics on gestational diabetes. Now, we don't know why, but for some reason, the rates of gestational diabetes are increasing in Quebec quite quickly. They've almost doubled between 2000 and early 2000s and later in closer to 2020. They are increasing in both Anglophones and Francophones, but particularly amongst Anglophones. So we're going to be studying this a bit more, and you'll have to wait a few years for the next presentation. Okay, just before we get to the question, I just want to acknowledge the source of the statistics that we've shown you. They were taken from 2 journal articles, Journal of Immigrant and Minority Health, and PLOS One. if you have questions, you could go ahead and
Thanks very much, Dr. Auger, for your presentation and of course for the important research that you're doing. So we'll move into the Q&A section, and questions were coming in fast and furious throughout your presentation. So we have around 15 minutes. We'll cover what we can. I'll start with the ones in chat which came in first. How does education lead to the distance traveled among 30 kilometers? That was something you mentioned in the first part.
So there's many factors that could cause that, but education usually is a marker of socioeconomic status. A woman is more likely to have a car or the means to go to the spot she'd like to go. So if that hospital happens to be further, usually the education is a marker of her ability to do that. Does that answer the question?
Yeah, you were looking at urban populations, right, Ned?
Yeah.
So it's not a case of a rural person who has to.
No, it's not a rural thing.
Right. Okay. And another distance question. Are distances traveled correlated with level of hospital? Example, level 1, 2, 3. And maybe you can explain what hospital levels are for the uninitiated.
Oh my goodness. I just want, again, the disclaimer that, I am not a specialist in the delivery of obstetric care and can't specify the details of all those kinds of hospital levels. But yes, okay, somebody's waving their hand.
Oh, that question is from Sandra. Go ahead, Sandra.
Yeah, so I'm a retired high-risk obstetrician. So level 1, 2, and 3 usually relates to the level of intensive care nursery. So level 1s can deal with low-risk moms and babies that are usually over 36 weeks, don't require intubation, etc. Level 2s, slightly more premature, and level 3s are what we know as our high-risk hospitals with maternal fetal medicine and intensive care nurses for the babies. Now, I'm not sure if the numbering system's the same in Quebec as it was when I was in Ontario and in Alberta, but so that's it. So generally the level 3s are sort of urban central, big urban central, and there may be 2 or 3 of them in the same city, depending on the size of the city. But they also, so they're not nearly as accessible, and that's why I wondered if it was correlated, because you're going to get your most high intensive care needs in those hospitals.
Thanks, Sandra.
What I can say in the hypothesis of the study is that that was one of the factors involved, but primarily the hypothesis was that Anglophones are more likely to select a hospital that's a bit has certain characteristics as opposed to the local hospital, and to pick an English hospital.
Thank you, Natalie. I'm now looking at the Q&A question.
Okay, go ahead.
Oh, I'm sorry.
No, go ahead.
Rita. Okay. There are growing number of Q&A questions. So first, could a French hospital also be local? In one of the slides,
yes,
you differentiated.
Mm-hmm. So, yeah, the local hospital is just, we didn't care about the language of the local hospital. We assumed that if you use that hospital next to you and you were Anglophone, it meant that you didn't have any special needs. There was no particular importance in terms of the language of the service. So it didn't matter because it's not really going to fit. You have a low risk of preterm birth or stillbirth. You're generally a healthy woman. But when you go to a farther hospital, there's a special need there. So these women here that are the ones that we were interested in. We just grouped everybody else in the reference as about one bunch.
Thank you. Now, here's a detailed question. Couldn't the risk be higher for those attending services in hospitals further from home simply because they need specialized services? So they're already higher risk cases for stillbirth.
Yes. So I mentioned that we expect these risk ratios to be higher because of that. That needs to be wiped from the mind now. We already know that. That if we had not found that all of these risk ratios were greater than 1, we would have been doing something wrong. So all these numbers that are above 1 confirms that issue, that those women are having a greater need because they have. Now, that is not the question. Now, the question is, in a perfect world, there would be, a higher risk of preterm birth than of stillbirth, because we want to prevent those stillbirths in those less healthy women. Like in this group here, this would be a perfect world. 1.5 would be greater than 1.1. So it's about switching the mind to looking at an inequality perspective. So what we would want to see is this 1.5 also here, and the 1.1 also here for those that have no high school diploma. That would mean that we're doing our job well. I hope that answers the question.
Thank you, Nathalie. A couple of people are asking if you could share your PowerPoint, and someone asked about the methodology, but I assume that's detailed in the 2 articles you cited. So I would suggest that when we send a follow-up email to the people here today, we'll include references to those 2 articles, if you could send them to Anna. And if you could let us know whether you're able to share your PowerPoint, please.
Yeah, no problem. I can do that.
That's great. Thank you. Another technical question. Were lethal fetal anomalies excluded when counting stillbirths?
No, we did not exclude lethal fetal anomalies. So, okay, yes, I think it's a good question. There's different causes of stillbirth, different causes of preterm birth. Some stillbirths cannot be avoided. So this is a mix of all that, because we couldn't distinguish the reason for the stillbirth or the reason for the preterm birth. We're using vital statistics data. So these are average of all the kinds of stillbirths and averages of all the kinds of preterm births. So if we could have taken out stillbirths that could have not been avoided, well, that would have helped, but we could not do that in this study.
We've really got you on the hot seat here, Nathalie. There's another question. It's in 2 parts. High school Anglophones served in a further English hospital have significantly highest risk of stillbirth. How can you explain that? I'm not sure if you have anything to add.
Here, so the 1.4 versus 1.4, is that the question? Yes. So yes, I think it's a very good question. I think I understand it, right? So on its own, socioeconomic status is associated with lower socioeconomic status is a risk factor for any adverse health outcome, not just preterm birth or stillbirth. So this is not good either. But that was not we're kind of attempting with this row here to rule out an effect of socioeconomic status here. So ideally, we'd want to see these results over here too, in the francophone hospitals, the French hospitals, but that's not what we see. So I just want to point out all the questions of that's a really excellent question. Now this there's something going on here too. There's work to do in the kind of like potentially in the English hospitals as well. But the problem is not as serious as in the French hospitals. Yes, of course that there's some delay happening here. Something is causing all people that have no high school diploma to have a higher risk of stillbirth.
That questioner went on it in another point to say even if the risk, it's more a comment, even if the risk among no high school.
Sorry, I didn't.
Yeah, sorry, it's just a comment. Even the risk among those with no high school served in further French hospitals is higher. The confidence interval is very wide and imprecise. We can share the comments with you later if you like, Nathalie.
Yeah, so I didn't speak about like about the focus on statistical significance. There's a lot of debate in that. So one of the things about statistical significance is that it's a question of precision and having enough births. There are not many stillbirths anyway. Stillbirth is a very rare thing. We're talking about like 4 per 1,000 births, so 0.4%. Please focus on the trends at all times in this presentation. This is the important here. So the trend 1.5, 2.2, 3.0. That is the important trend. I mean, I didn't highlight that or discuss that, but it's the overall trend. There are few stillbirths, but amongst those few stillbirths, births, there are few births among the no high schools and the further French hospitals. But amongst those births, there is a very high risk of stillbirth.
We have 2 more questions and just about time for both of them. Is there a way to look at the frequency of complications in births by language concordance of the hospital?
Well, we did not analyze that specifically, because those French hospitals are mixed in here. It's like a different study, different kind of research
so
question.
It's possible. Okay.
Yeah.
Okay.
That was Jennifer Johnson from CHSSN, by the way.
Oh, okay.
Okay. One last question, and then we'll have to wrap up. And it's a policy question. And at Questgren, we always try to see if we can, how the research can be linked to policy to help support us in the work we do talking to government when we can. So the question here is, do you have thoughts, Nathalie, on how Bill 15 may continue to affect the outcomes of Anglophone women during pregnancy? So Bill 15 is the very recent legislation passed to create a new structure called Santé Québec.
I honestly I can't answer that. What I can say is that our team is concerned by these people, disadvantaged Anglophones. That's what our concern is. And that's the only thing that I can comment on. Honestly, we see this. When we see this, we're worried. This is not right. There should not be, this number here should be inverted. It should be flipped. There should be a 3 here and a 1.1 here. That's what we want to see. So until we see that, we're going to keep doing research, publishing, and telling everyone about what we find.
Thank you, Nathalie. And I forgot to mention at the beginning, Nathalie Auger is a Questgren researcher member, and one of our roles at Questgren is to help amplify the impact of research done through activities like today's. Thank you, Nathalie Auger, first of all, for your presentation with its very sobering statistics. Thanks everyone here for attending today's event. We always want to hear your feedback, and we invite you to fill out the evaluation form for today's Lunch and Learn. You will find the link in the chat shortly. Please stay tuned for coming events in our Lunch and Learn series. We've got quite a few of them coming up. The best way to learn about what's coming up in our programming is to sign up for a mailing list if you haven't already, or to follow us on Facebook or LinkedIn. And the links to get onto those resources will be in the chat now. In closing, we again recognize the financial support of the Secrétariat aux relations avec les Québécois d'expression anglaise and our other funders, Canadian Heritage, the Canadian Institute for Research on Linguistic Minorities, and Concordia University. So thanks again, everyone, and have a great day. See you next time. And Nathalie, there's just a flood of thank yous going in there on the chat. It's been very appreciated what you've had to share with us today. So goodbye, everyone, and take care.